Good afternoon, everybody, and welcome to our third session of the Kentucky School of Alcohol and Other Drug Studies virtual learning series. I'm going to give folks just a minute to kind of get into the session here, and then we'll get started. All right, everybody, welcome again. My name is Nikki Millward. I will be your host today. And we'll get started with just a few housekeeping items. The session is a webinar. All attendees are muted and videos are off. Please make sure you use the Q&A box if you have any questions that are specific to our presenter today. We will have our ASL interpreters with us on the screen throughout the session today. We appreciate your patience and grace with any technical difficulties we might have. The session is being recorded and will be available at a later date on our department website and our YouTube channel. We will drop the links to those into the chat there. In order to be eligible for your CEU certificate today, you need to be present for at least 90% of the session. Zoom tracks those exact minutes for us. You do not need to enter your contact information into the chat. Again, Zoom tracks all that information for us. Please make sure that you use the same email to register and to log into the learning sessions. The email that you've used today to participate in the session will be the email that is linked to your CEU certificate on the website. At the end of today's session, you'll learn how you'll receive communication from us about your CEUs, how to complete the session evaluation, how to access the certificate online, and please note the certificates from today's session will be available after November the 1st. Today's agenda, we're going to have a presentation from Dr. Michelle Loftwall. That'll be followed by our CEU instructions from Ms. Diana Hobbs, and then I'll close us out today with just some upcoming training session information. The Kentucky School Learning Series is administered through the Department for Behavioral Health, Developmental, and Intellectual Disabilities. We just wanted to share here our mission, vision, and values statement. So for our presenter today, we have Dr. Michelle Loftwall. She is a professor of behavioral science and psychiatry at the University of Kentucky College of Medicine in the Center for Drug and Alcohol Research. She is the Bell Alcohol and Addictions Chair and Medical Director of the First Bridge Clinic, which provides comprehensive outpatient opioid use disorder treatment to patients discharging from emergency rooms and inpatient medical surgical services. Her research has been funded by the National Institutes of Health and Industry and is focused on improving the treatment of persons with substance use disorders. She was an expert panel member on SAMHSA's Treatment Improvement Protocol, TIP 63, for medication treatment of opioid use disorder, a past board member of the American Society of Addiction Medicine and president of the Kentucky chapter of ASAM. She was an invited speaker at the National Academy of Medicine and recipient of several medical student teaching and mentor awards. With that, I will pass it over to Dr. Loftwall.
Thank you for that very kind introduction. Let's see if I can share my screen, get my slides up for us all. We're almost there. Okay. And now I need to make it big. All right, welcome everyone. So I'm really pleased to be here with you this afternoon. We're going to talk about what families and communities should know about opiate use disorder and FDA-approved medication treatments for it. I'm going to start off with some definitions, then we'll talk about a brief history of what was often ineffective opiate use disorder treatment. And you'll see I'll abbreviate that as OUD. And then we'll talk about the medications for OUD, and that's abbreviated as MOUD, of what the evidence base shows, and how the medicines work. We'll talk about elements of treatment, what treatment looks like. We'll talk about some criminal justice data and implementation considerations, and we'll end off with some resources, and we should have plenty of time for questions and just discussion at the end. So to start with, opiate use disorder, the criteria are listed in the DSM-5. You want to have more than 2 items in the last 12 months. And these are the criteria. There's 11 of them. What they did was they took DSM-4 and they combined them, the definitions of abuse and dependence, because they really realized that use disorder was really along a continuum. It wasn't that everybody had met the criteria for abuse and then later on developed dependence. So it really made much better sense and was more consistent with what happened in the real world to think of this really as an opiate use disorder as one single disorder that varies along a continuum of severity. So the criteria include when the use of opioids results in a failure to fulfill responsibilities, using in physically hazardous situations, having cravings or urges to use, having social or interpersonal problems due to the use, using larger amounts or longer than what was ever intended, wanting but failing to be able to cut down. Let me go back. Sorry. Spending more time to get, use, and recover from the substance, giving up or not taking part in other important aspects of life, and having ongoing use despite problems, and of course, tolerance and withdrawal. So when we teach about these, I like to just try and teach the 3 C's. It's much easier. I think it's what it really speaks to is loss of control over the use of a substance, having cravings for it or urges to use, and compulsive use despite harmful consequences. So you total up the number of items that the person is experiencing, and that tells you whether or not it's a mild, moderate, or severe disorder. The essence of really any substance use disorder, that is opiate use disorder or an alcohol use disorder or stimulant use disorder, is that it's a brain disease that's expressed as compulsive behavior, whereas there's a persistent use despite harmful consequences. It's a behavior that develops its own drive or appetite, just like sleep or appetite, where if you deny someone sleep, you deny them food, that slowly but very strongly, the person will start to do anything that they can to gain access to sleep or gain access to food. And they'll do things that they otherwise wouldn't do in the context of being restricted from sleep or from food, such as falling asleep while driving, falling asleep while seeing a patient. And then if you're stuck out in nature, for example, and you lose access to food, you might consider eating, some bugs or other things that you wouldn't normally do. So it's really this intrinsic, unconscious appetite that develops and can become disordered and with other things such as substances. And so really the brain has changed once it becomes addicted. What was initially conscious has moved to unconscious circuits affecting motivation and reward, and the brain's really quite altered. So the brain changes have been highlighted in the U.S. Department of Health and Human Services Surgeon General report, Facing Addiction in America in 2016. This was a really seminal report that was talking about addiction in the United States. And there's a whole chapter that talks about the neurobiology of the brain changes and really puts it into layperson's language. It features this picture here that you see of the brain and tries to really explain that this isn't just a simple matter of choice that someone can easily control on their own. Really, it's trying to explain that this is a legitimate disorder, that there's a lot of science that shows that there are brain changes, and the changes are involved in several different areas. Here, there's changes in the brain that have undergone in areas such as the basal ganglia that are involved with intoxication and what has now become salient to someone that wasn't in the past. There's areas of the brain that are involved with reward and stress and how withdrawal and affect are related. And this is in part of the brain called the extended amygdala. And then there's other executive function deficits in our frontal lobes or our prefrontal cortex, shown here in green, that have to do with preoccupation and anticipation of reward. What we have known for a long time is that substance use disorder is often a chronic relapsing disorder. It's not like acute appendicitis where you can go and take the appendix out and that you're then cured. It really is more similar to chronic illnesses like type 2 diabetes, hypertension, and asthma, all of which have components, environmental and behavioral components as well. So when you look at each of these conditions and you look at the percentage of patients who have a return to use or an exacerbation of their diabetes, high blood pressure, or asthma, what you see is that it's quite common to have not to have perfection, even when treatment is on board. That we know that we have friends and family who have type 2 diabetes and that they struggle controlling their blood sugars despite being on the medication, that they can still have trouble with having blood pressure exacerbations or elevated blood pressure, even though they might be receiving treatment for high blood pressure, and same for asthma. The problem with opiate use disorder in particular is that a single exacerbation can sometimes result in loss of death. So that's why we say, you know, that drug addiction is often much more unforgiving than these other chronic illnesses. So what causes it? It is multifactorial. I mean, there's lots of different things that impact its development and the maintenance of it. So we call it a complex disorder. This is similar to other disorders like diabetes as well, where there's a contribution of genes and a contribution in the environment. And it's about a 50-50 split. We determine this looking at twin studies, reared apart, reared together, and identical and fraternal twins. And in the environment, we know that things that affect the expression of and development and sustainment of a substance use disorder include things like whether or not what substances are available in the environment, whether the peer or social network is also using, whether or not there's drug using partners or family members, and whether there's a history of victimization or adverse childhood experiences. So just a few more definitions. Remission of opiate use disorder. I don't think we use this word enough, remission. This means no more signs or symptoms of the opiate use disorder. We want opiate use disorder to go into remission, just like we want cancer to go into remission. It can be very, very difficult to have a beautiful recovery if the disorder is still having signs or symptoms. So recovery is the act or process of becoming healthy after an illness or injury. It's also a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. Recovery is built on access to evidence-based clinical treatments and recovery support services for all populations. This is SAMHSA's definition. So I just want to emphasize this, that recovery is built upon access to evidence-based treatments, right? It would be really hard to have a beautiful recovery from cancer if you're not given access to evidence-based cancer treatments. And recovery support services. So, you know, these are also very important. And we'll talk about what recovery support services are in just a minute. But I think these terms are just critical for us to be clear about. Recovery, remission, and treatment are not the same thing, but they go beautifully together. We don't need to wait to start thinking about recovery until someone's in remission. We can start having treatment, working towards remission, and be in recovery all at the same time. They're not at odds with one another. Recovery support services are services that support 4 major dimensions of a life in recovery: health, home, purpose, and community. With regards to health, the aim is to help overcome and help someone manage their disease or symptoms, whether or not that's achieving abstinence from all substances, making informed, healthy choices that support the person's physical and emotional well-being, having a home, a stable and safe place to live, having a sense of purpose, having some conduct of meaningful daily activities such as a job, school, volunteering, family caretaking, creative endeavors, and having the independence and resources to take part in society, and being part of a community, relationship, and social networks that are providing support, friendship, love, and hope. All of these things are important for all human beings. So some history of recovery and some early treatment. So there was no effective evidence-based treatment in the early 1900s. In AA, Alcoholics Anonymous, that began in 1935 with the motto of taking one day at a time. And it really did take a chronic view. Members relapsed, they took all members took other members back without judgment. The idea was that you worked the 12 steps into a way of living because the adversary was death. They accepted that people needed to go to the hospital for acute treatment and that there was a loss of personal control. And this is all wonderfully documented in a documentary called Bill W. I listed the reference down there if you wanted to look at it in AA's big book. The important implications here that are still so true today are that recovery is a lifelong process and that there's no guarantee of abstinence, and really just emphasizing the importance of hope, fellowship, and more than oneself. So this idea of purpose. Then we had acute models of treatment, including ECT and prefrontal lobotomy. These were grossly ineffective. And then we had multiple detox or medically supervised withdrawal involving recovery models. And one of these was actually developed at the Public Health Service's Lexington Narcotics Farm that went back into the mid 1900s. And then medication-free rehabs. Unfortunately, while someone could do quite well when out of their environment and in a setting where there was no access to illicit substances, and even if you were trying to do counseling, working on people's coping skills, doing relapse prevention, providing lots of psychotherapy, what was found is that when people went back to their environment, that over 80% returned to use. And so this idea that you could cure it really was not upheld back then in the 1900s. And we've tried this multiple times since, and we get the same result, is that people need ongoing treatment and recovery. So we've done this repeated attempts to cure. So the narcotic farm, this is just a picture of it, that opened in 1935. And the attempt really was to cure, but over 80% relapsed. And we've shown this over and over again with multiple National Institute of Health funded studies. We find that people die in general 20 years earlier compared to those that don't, who don't have a substance use disorder. And the risk factors for death with opiate use disorder involve, one of the biggest risk factors is loss of tolerance to opioids. So we see very, very high overdose rates when people are leaving jails, prisons, where there's frequently not access to medication treatment. So it's leaving these controlled environments where they lose tolerance, and then there's a return to use in the absence of having any medication on board to prevent that overdose. So why were recovery support services and early treatments not curing addiction? And I think it was really a failure to understand what addiction was. We really didn't have the science to show what we talked about earlier with the brain changes. So there was still these ongoing thoughts that, it's a behavior, it's a choice, people should be able to stop on their own, if only they could try harder. And, we didn't have effective treatments until the 1960s. So there was also this idea that, addiction, you just had to get through the painful withdrawal. But it's so much more than physical dependence. The brain has really changed. And now we do have the decades of research showing that, it's not an allergy, it's not a character flaw, it's not a spiritual deficit. It is a treatable disorder, but it's often chronic. And so we really have to have more of the idea that we're managing it, we're trying to put it into remission, we're assisting with recovery as best possible, but we respect it as a chronic illness that can recur, and really trying to think of it more like type 2 diabetes. There is lots of misconceptions and misinformation that bring stigma and discrimination and make it harder to access treatment. So saying it's a brain disease means the individual has no responsibility. This is not true. So people are still, they're not a rat or an animal in a maze or lever pushing. People still are responsible. We hold people responsible for their actions, but treatment really helps dampen the drive to use illicit substances. And so we want people to have access to treatment. It's a marker of a spiritual flaw. No, very wonderful people with various, strengths in their spiritual life do become addicted. It's not a marker of a spiritual flaw. The spirit can certainly become hurt and damaged, and growing back, part of someone's spiritual life is certainly part of many people's recovery. It should be possible to stop on your own because it's a behavior. This is not true. This is also false. You all probably have had experiences where you would like to stop a behavior, and just because you wanted to do that didn't mean that you were able to just stop. I will sometimes notice that at the end of my day, when I drive back home, I always take the same way home from work. If I'm told that I need to pick up something extra from the grocery store on my way home, if I've had a really busy day and I don't really have that at the top of my mind, I've been known to forget and just automatically go back home. It's like, and I don't even remember driving, through some of the stop signs and stop lights. It's like I'm on autopilot. This is because our behaviors that we repeat over and over again are become ingrained in unconscious parts of our brain, right? Like I'm talking right now, but I don't have to think about every word that comes out of my mouth. When I walk, when I ride a bike, I can just walk and ride the bike. I can think about other things, where I'm going, what I need to do when I go there. The behaviors become unconscious. So this is a behavior, taking of the substance, that has also developed unconscious pathways. Medication-assisted treatments, just replacing one addiction for another addiction. No, that's false. So when someone's on medication treatment, they can go into remission and they can have a wonderful recovery and be quite healthy and enjoy positive relationships with others, be employed, and you've no more signs or symptoms of the illness. So that is no longer, that's not replacing one addiction for another. Medication is supposed to be short-term. This is false. We've demonstrated with many, many studies over time, over the last 100 years, that return to use is the most common outcome. Can some people be on medication short-term and be cured and be in long-term remission? Yes, that can happen. Looks like that can happen in 15 to 20% of cases. Unfortunately, we don't have a way to determine who that is. There's no blood test, nothing else. And you could say, well, that's a sign that it's not a real illness. No. Think about type 2 diabetes. Don't you know some people that with lifestyle changes, changing their diet, changing their exercise, that some of them still needed to be on medication? Maybe some didn't. Maybe some were able to come off medication or minimize the amount of medicine, change from insulin, go on to oral hypoglycemics. But we would never suggest that everybody who has type 2 diabetes should only be on insulin or metformin for 30 days, 60 days, or 90 days. We look at each individual. We try to make sure that the person with diabetes doesn't lose their kidneys and go on dialysis, doesn't suffer complications where they're going to lose their eyesight, lose their limbs because of peripheral vascular disease that's associated with poorly treated diabetes. So we need to treat substance use disorder and opiate use disorder like we do other chronic illnesses that have both a component of genetics and the environment.
Dr. Lawful.
Yes.
This is Diana. We had a question come in, the question and answer, and this is the question. If the medication is not meant to be short-term, and if they must take it, why is it not replacing one for another? Could you address that?
I think because, we think about like heroin and like fentanyl, there's a need, if you're going to take those, you're going to have to take them to maintain your tolerance many, many times a day. And in doing that, you're not able to really function quite well. It prevents you from going to work. You're having kind of chronic ups and downs, right? Because it's a very short acting medication. It is a medication in some countries. It's not in the United States. And it's associated with lots of poor health outcomes, right? So, with lots of times people are injecting it, they're getting HIV, hepatitis C, they're becoming bacteremic. They're not improving function, right? They're sick. And so in contrast with the medication treatments, methadone and buprenorphine, they're very long acting. You don't have like fast onset and fast offset, and you're preventing someone from having like ups and downs in the brain that really are kind of causing chronic cycles of intoxication and withdrawal versus being on a daily or even, monthly medication. Some of these medication treatments are given as a monthly injection. Just, it really kind of helps have better homeostasis, a kind of a chronic level that helps prevent disturbances in like the hypothalamic pituitary axis and a whole host of other areas in the brain. So it really allows someone to start making different choices. It dampens down the drive. You see less illicit drug use, less risky behaviors, and you have an overall increase in you have an overall decrease in risk of death, both all-cause death and mortality and overdose death.
Thank you.
So one of the things that we're noticing, we're quite worried about with the prescription opioid epidemic, it was largely Caucasians that were dying. And as the epidemic has continued, and we now have more heroin overdose deaths, and then now fentanyl, that's frequently, it's illicitly manufactured fentanyl. It's not fentanyl like patches that are being prescribed. We're seeing that in Kentucky, an increase in deaths among Black persons and Hispanics at a higher rate of increase compared to whites. And so there's really a need for us to make sure that we're reaching all ethnicities. There's a worse outlook when it comes to access to treatment, where when you are offering access to treatment with medication, that whites are more likely to be offered it than the other races and ethnicities. So we need to make sure that we're doing a better job making sure that we're providing equal access. So there's 3 FDA approved treatments. And so these really have to be part of the answer. There's methadone, which is a full agonist. There's the partial agonist buprenorphine, and then there's the antagonist naltrexone. So they all work at the mu-opiate receptor, which is the receptor that is all over your brain, and it's also in the body, like in the gut. The mu-opiate receptor slows down your gut. That's why you get constipated when you take opioids. And it's in the respiratory centers in our brainstem, the part of the brain that's called the medulla that controls your breathing. And so when you take those, the mu-opiate receptor, and you stimulate it there with a full agonist, and you increase your risk of having an overdose death because it can stop breathing. So, and then you have opiate receptors in parts of your brain that control like your emotions, that control things like memory storage, motivation, energy. So the mu-opiates are all over the place. The full agonist methadone is long acting, and the only way to get access to methadone is through an opioid treatment program. And Kentucky has several of these. Methadone, when given for an opiate use disorder, is always dispensed under supervision for the first 90 days of treatment. It's heavily regulated by the federal government and by our state substance abuse treatment authority. Kentucky has several opioid treatment programs. Some states only have one. Because you have to go so frequently and it takes a long time to get any take-home medication, it sometimes can be a barrier for people to access methadone. But in general, I just want you to know that people who are in methadone treatment, they work very hard to be in methadone treatment because it is quite demanding on patients. Partial agonist buprenorphine is a partial agonist because as you increase the dose, you really don't, you get to a maximal effect of buprenorphine, and then as you increase it, you don't get any more effect, and we call that a ceiling effect. So you can never get the full opioid effect from buprenorphine as you can with a full agonist. So buprenorphine, you can get that also through a opioid treatment program, but you also could get it from your primary care physician practice, a federally qualified health center. You get it from an outpatient addiction treatment program. You can really get it from any DEA licensed provider. It's a Schedule III medication. I should have removed here where it says you must be waivered. There's no more waiver, and there's no more patient limits on this. There had been in the past, but in the last year, the waiver was removed. And in large part, it was removed because it was a barrier to treatment, and buprenorphine is just been shown to decrease the risk of death. So our federal government recognized this and has really kind of trying to help people gain access to it, since it is more widely available. And now naltrexone also sits at the opiate receptor, but it doesn't stimulate it at all. And for this reason, it's called an antagonist. So if you were to think about it as like, if you were to think about all of these medications as sitting in a receptor, like a outlet, methadone would plug into the outlet. And as you increase the current, you'd get increasing electricity. And as you keep increasing the electricity, it's going to get brighter and brighter and brighter and brighter. Buprenorphine is like plugging into like a surge protector, right? So it delivers electricity, but as you increase the electricity, there's going to be a certain amount that it's just not going to go above. So that's the partial agonist. And naltrexone's like the child safety cover. So it's not letting any electricity go through. So it's just plugging and covering. So the first two medications here that have the asterisks, methadone and buprenorphine, they are included on the World Health Organization's list of essential medications. And this is a big deal. To get onto this list, you have to be able to demonstrate that in low and middle income countries that there is a clear positive effect on public health. And so methadone and buprenorphine have both demonstrated a decrease in death and a decrease in the spread of infectious diseases. So this shows you how the three medications work. So you all might be aware that Kentucky has been part of a big national study to it's one of 4 states to try and decrease opiate overdose death by 40%. And in doing this, we've been working really hard to try to increase communities' knowledge about how medications work. And this is one of the flyers that's been generated and distributed to try and just increase the understanding within our workforce and within communities. So you can see here a table that shows you methadone, buprenorphine, and naltrexone. So methadone and buprenorphine, both because they have some agonist properties, so they're delivering some electricity basically when they bind to the receptor. They help treat withdrawal. They both help decrease craving. They both provide some analgesia, and they both have been shown to decrease infections and decrease crime. This is specifically property crime. And you don't need to go into withdrawal. There are methods for buprenorphine where you don't have to go into any withdrawal at all. Buprenorphine, though, in general, you might have to go into some mild withdrawal. And there's data to show for both of those that you decrease mortality. With naltrexone is also FDA approved, but because when it binds, there's no stimulation of the receptor, it's not treating withdrawal. So you have to make sure that the person has gone through withdrawal before they can actually be placed onto naltrexone. It reduces craving somewhat, no strong effects on helping with pain, and not any data showing that it helps reduce crime. And you do have to go through withdrawal, which can be difficult to get someone through. And there's no adequate data showing that it saves lives. So you all could say like, oh, she's really against naltrexone. I'm not really against naltrexone. I'm sharing you what the science shows. When I'm seeing patients, I tell people about all 3 FDA approved medications. I explain to them how they work, what the benefits and what the risks are. And when we talk about the individual and what they're looking for, what they want to take, it's really, as long as the right medicine for the person is the medicine that the patient is willing to take. We need the receptors to be bound by one of these 3 medicines in order for the person to be protected from an overdose. So if the person wants to be on naltrexone, and let's say they've just gotten out of jail where they've gone through withdrawal and they have not yet returned to use, this is an ideal time to start naltrexone because they've already gone through withdrawal. If this is someone who's actively using heroin or fentanyl, and they are so afraid of going through withdrawal, and they've tried before, and they just, they're so worried, they've already had overdoses reversed with naloxone, and, they just, really don't want to do that. And furthermore, like maybe they've had experience with buprenorphine and methadone, they felt like that worked for them, then, naltrexone's not going to be a good option. It could actually increase their risk because trying to have someone lose their tolerance is always a risky period without having one of these 3 medications on board. So how do the treatments work? So what they're doing is they're reducing illicit and risky drug use by suppressing withdrawal symptoms. And so methadone and buprenorphine both do that. They suppress the craving and drive, that physiological innate drive in the brain to use. So they do that. And they help stabilize the level of dependence, the tolerance level. So methadone and buprenorphine do that. And then in doing this, as long as the patient's taking their medication, it blocks the illicit opioid effects to help make it so that when the person returns to use of heroin or oxycodone or fentanyl, that it's a waste of money because the medicine is on the receptor and is preventing that heroin or fentanyl from binding there. And so it's through that you get extinguishing of a behavior. And doing that also, because the medicine's bound on the respiratory center, it protects the person from having a fatal overdose due to fentanyl or whatever that illicit opiate is that they're using. So when you decrease the physiological drive here, that can be an incredible experience for the patient. It really opens up their sense that they can make different choices in their day. They're not feeling like they have to be thinking about where they're going to get their next dose or where they're going to get their next supply, how they're going to be find the money to do that. And so really dampening down that drive is very, very therapeutic. And then, so it opens up choices for the person. Now, what choice they make, this is going to be available. It's going to depend upon the choices that are available to them and their environment, and then also what they've learned over time and what their situation is. And so this is where we know with regards to conditioned learning, the type of, and here we're kind of going back into like basic psychology with like Pavlov and Skinner. And so what we know is that punishment is not an effective deterrent. Punishment does not make behaviors go away. People just generally hide them. What does work is positive reinforcement. And so trying to have healthy options within communities, are there social networks that are pro-social? Is there a recovery group that the person can join into? Is the drug court willing to allow the person to make amends by if they owe, days in jail? Could they do that on their days off from work so that they don't have to lose their job where they're now a tax-paying citizen? So how can we construct communities and the people that they're working with to start changing the conditioning for the person to support the remission recovery, support staying in treatment, and so that the patient is then making choices that are supportive of them staying in remission and having a beautiful recovery. So here's some important contemporary data. This is a study that was done in Baltimore City. It was published almost 10 years ago. And this is at the time when buprenorphine was becoming much more widely available. And Baltimore City has always had a significant problem with injection drug use. About 1 in 10 people that are Baltimore City residents inject drugs. And usually it's been heroin and cocaine. And what they did was they made treatment available upon demand, both methadone and buprenorphine. And what you see here in the circles is heroin overdose deaths. And the squares are the methadone treatment. So they increased the number of methadone treatment slots that were available. But they also massively increased, I should say, the buprenorphine treatment slots. Those are the triangles. And what they saw in their statistical analyses while controlling for heroin purity is that as they increased their treatment slots, they saw a statistically significant decrease in heroin overdose deaths. And so this was a very much needed trial in the United States. Similar data had been shown in Europe, but had not yet been shown in the United States. And so this was very powerful data to really support, having like things like Medicaid, that it should be a covered, methadone and buprenorphine should be covered treatments on Medicaid. And they now are in Kentucky, which has really been so helpful. Here's some other important big data, right? And I'm showing you this also because these are data that are real world, outside of, randomized clinical trials, where people will sometimes say, well, that's great, but those people are getting so much attention, and that's, randomized clinical trials are not the real world. That Baltimore City trial, that was real world. And here's another real world study. So this is data from Massachusetts. And so in Massachusetts has some regulations that actually allow the equivalent of their state prescription monitoring program, like their CASPR, to be connected to their hospital records and their death reports, so that you can actually track an individual and what medications they're getting, and like they're also whether or not they die or not, quite easily. And so what they did was they were able to identify a cohort of persons who had a non-fatal opiate-involved overdose. And they followed all of those people for 12 months. And they looked at whether or not over those 12 months, whether people got onto methadone maintenance treatment, that's the MMT, the triangles, they got onto buprenorphine, which is the squares, or naltrexone, which was the diamonds, or if they got on none of those, so no MOUD. And what they looked at was the cumulative incidence of all-cause mortality or death. And so the stairs up, the solid line, is death among those who are on no medication treatment. And you see that there's increasing death among people who've had a non-fatal overdose over the course of 12 months. And then if they're on any of the 3 medications, that there's a reduction in death greater than 50%. Unfortunately, there are very, very few people on naltrexone in this study. So while you see that looks like it has the lowest rate of death, there were so few that it didn't reach statistical significance for naltrexone. The average period of time that someone stayed on naltrexone was only 1 month. Now, so this is great, right? Like, let's get people onto medication. We're going to decrease their mortality. What happens then if they're on treatment and then they come off treatment? So what you see here is then what happens, so for the people who are on naltrexone, and then they, I told you the average time that they were on it was only 1 month. And so when they come off of it, you see that their mortality in the diamonds is just starting to look like they were never on it, right? They're dying. And then the people who were on methadone and buprenorphine, they are also, their mortality risk is increasing it's heading back up. So really, this is the study, I think it's real world, that is showing you that it's important to get onto medication in order to decrease your risk of death, but it's also important to stay on it as long as needed. Okay, so here's another study. This is a study that was done in Sweden by Johan Kakko. He was a psychiatrist. And Sweden has always had very stringent regulations with regards to methadone and buprenorphine, where they would want to see people fail many other types of treatment before allowing someone to get onto methadone or buprenorphine. And so Dr. Kakko really thought that this was nonsensical. He's seeing people pass away before they even had an opportunity to get onto medication. And so he devised this study where everybody there were 40 people, so not a lot, were randomized to be allowed to be on buprenorphine maintenance over a year. So you're seeing a full years of days here on your x-axis, and that's the red line, or to be randomized to undergo detox. So getting onto buprenorphine, but then being required to come off of it. And both of the treatment, all the people in both arms of the study had access to very enriched psychosocial services. So there was family therapy, individual therapy, there was, vocational training, It was really kind of like the works. And what they saw was just that, people dropped out that were forced to detox. And furthermore, there were 4 subjects in the control group, in that detox group, that died of a fatal overdose. And so this was just further support of, we really need to allow people to stay on medication as long as they're benefiting. This is some more meta-analysis data. This to show you that in comparison to the general population, people who have opiate use disorder and never receive any medication treatment, they have a 6-fold higher risk of death. These are standardized mortality ratios. And then if they're allowed to be on medication and get onto medication treatment, that rate of death goes down by more than 50%. It's still elevated compared to the general population, but it is much better. And so, if these were treatments for breast cancer, prostate cancer, lung cancer, these would be, really embraced by the medical community and by the community at large. So this is one of the reasons why we're trying to, I think, do this education today, is just to really show you that there's a very strong evidence base surrounding these medication treatments for opiate use disorder. So why is maintenance treatment important? It's really important because it decreases adverse health and social consequences, including in pregnant persons. It increases the psychological and physical health and well-being of the individual and also families and communities, decreases illicit drug use, doesn't always eliminate it, it can, but it does absolutely decrease it. It decreases the spread of infectious diseases that are associated with illicit drug use, like hepatitis C, HIV. I would say also we're just, seeing lots of other kind of nasty infections like endocarditis, osteomyelitis as well, with untreated illicit and injection drug use disorders like opiate use disorder, stimulant use disorder, decreases criminal behavior, especially property crimes, and decreases the morbidity and mortality from drugs and drug-related behaviors. What about the treatment duration? People say, well, how long is treatment? So I like to just say, well, do you say that to someone with type 2 diabetes? And do you say that to someone with hypertension? How long are you going to be on this? I get it, but at the same time, it's time that we start thinking about what really, really, really kind of think about this like those other disorders. It's really as long as the patient is benefiting and needing the treatment. There's no time limit. All the FDA approved medications really do need to be made available to persons with OUD. We're in the midst of, an ongoing opioid epidemic that's been going on for quite some time now. And I think the latest data is that less than 15% of people that have an opiate use disorder actually ever are on one of these FDA approved medications. And so this is disappointing, but it's also like, okay, we can do this, we can improve this, and then we can help save a lot of our families and friends. So these are some treatment guidelines. There's medications for opiate use disorder that's published from SAMHSA. This is meant for families, policymakers, families. It's a free download. And then there's ASAM's executive summary for national practice guidelines for the treatment of opiate use disorder as well. And they also, make it quite clear that the standard of care is that the person be allowed to stay on medication for as long as they're benefiting, and that this can be lifelong. This is the data that I was just mentioning, that there's a huge underutilization. There was a recent large-scale retrospective review that found that only about 15% of patients with opiate use disorder ever received an FDA-approved medication. Usually this was buprenorphine or methadone. As part of the Healing Community Study, we've been trying to destigmatize the treatments. I think it's really hard for people who have a stigmatizing illness to come out and speak about how treatment has helped them, in contrast to, other diseases like Parkinson's or cancer or diabetes, where people may be willing to openly share that, they're receiving treatment and have that illness. So this is one campaign that you may have seen if Maybe you were in one of the communities where the study's been active. And this is Alex. He says, I'm a husband, I'm a father, and I take methadone for my recovery. Methadone gave me the chance to be there the day my son was born. Today, I get to create beautiful memories with my wife and son, all because I have a new way of life. This is Lydia. She says, I'm a granddaughter, daughter, and mother to 3 beautiful girls. I'm a volunteer and recovery support specialist. I take buprenorphine to support my recovery. And so Lydia says, after exhausting many pathways, I reached out to facilities that offered medication. Adding medication was the missing link for me to finally reach a point where I could enter recovery and stay in recovery long term. If you would have told me 6 to 7 years ago that I would have the beautiful life that I have today, I would have told you that you were delirious. Life is by no means always rainbows and butterflies, but man, it sure is beautiful. So what we're really trying to do now is make sure that patients can receive the care that they need in all the places where they go. So we want medical facilities, that's like hospitals, rehabilitation facilities, skilled nursing facilities, substance use treatment programs, emergency rooms, urgent cares, all to feel confident in screening for opiate use disorder and other substance use disorders, and when indicated to start treatment, if the patient is willing. And so, you know, there's this is a life-threatening illness. And so it makes a lot of sense that if someone presents to an emergency room for a big old abscess in their arm due to injection drug use, that the person be screened for an opiate use disorder and offered to start buprenorphine in the emergency room. We have a really strong evidence base to show that this is very effective and increases increases the likelihood that someone's going to follow up with addiction treatment. We want medications to be allowed in recovery housing, and we want our criminal justice system, where there's a very high risk of overdose death, to allow and to encourage evidence-based treatment. This includes our drug courts as well. Correctional settings with MOUD, just some really lovely examples of how treatment, when made available, can really be quite helpful. In Rhode Island, the Department of Corrections has made it all 3 medications available to incarcerated patients. And in the first year that they did this, they saw the post-incarceration overdose deaths due to involving opioids be reduced by 61% in just the first year. In England, after a prison-based buprenorphine and methadone program started, they saw 75 and 85% reductions in all-cause mortality and opioid overdose deaths, respectively, within the first month post-release. And in Australia, they saw that prison-based methadone and buprenorphine reduced suicides while in prison. We know that there's comorbid conditions and behaviors that we need to address within the care continuum. Most people who have an opioid use disorder, you know, there's other things that are going on as well. We know at the patient level that there's frequently there's more and more injection drug use and associated infections that we also need to be addressing, and other psychiatric comorbidity with lots of complex psychosocial needs and criminal justice involvement that can all complicate treatment. We know also beyond the patient that we have issues with workforce, and I think Kentucky is doing a really good job trying to train up our workforces, and also to make sure that our medical students and residents, nurses, all of our healthcare professionals, that we're doing more training on evidence-based treatment. We have an improvement in our healthcare system, specifically within Medicaid, to help ensure that there is not a burdensome PA process to try and get people onto these life-saving treatments. But we still know that within Kentucky, especially in our rural areas, that it can be very difficult to find clinicians offering these treatments. We still have lots of issues with stigma, discrimination, and ADA violations. And so these can be things that make it difficult to initiate and retain patients. Here on the left, I just show you a slide of the United States. You all may be aware back, I think it was, I'm forgetting what year, it wasn't that long ago, when there was an HIV outbreak in Austin, Indiana, which was just across the river in Louisville, that was due to a community that actually had immigrated from Appalachia and was largely injecting hydromorphone. So it's very intergenerational, parents, grandparents, adult children who were injecting and sharing injection equipment. And there was a very large outbreak of HIV there. The CDC came in and was quite concerned because it was not an urban population. It was very rural. It was a depressed area that had lost a lot of jobs. And so they did a study looking at where would the next HIV outbreak be that would be similar to Austin, Indiana. And what they found are all these green dots that they felt like were at risk. And so you can see a lot of these are in Eastern Kentucky and in the Appalachia region of our neighboring states. And so it was in part, I think, some of these data that led to Kentucky's overwhelming support for the development of syringe support programs, because we know that those programs help decrease the risk of spread of HIV. And I think it's wonderful that we can say today that Kentucky now, I think, has outpaced the previous #1 state in the number of syringe support programs that they have. #1 previously was New Mexico, and that we've avoided some HIV outbreaks that have occurred in some of our neighboring states like West Virginia that really have not widely adopted syringe support programs. And so here we also see in the middle, this is also opioid-related hospitalizations across the country. So we're seeing that with untreated opiate use disorder, I would say 10 years ago, it was hard for me to say that a majority of my patients were injecting. Most of them were still just using by snorting. Now, almost everyone has been injecting, and the opiate use disorder dates back many, many years. And so with more injection, you get more bacteremia, more sepsis, and more serious infections like in the heart valves and the bones. And so this is happening across the country where you see more opioid-related hospitalizations. And then these are some data from North Carolina on just the number of endocarditis hospitalizations over time. And you can see that we really had a large increase in the drug-associated endocarditis. So we've seen this here at the University of Kentucky, where there's a lovely hospitalist, Dr. Laura Finucchi, who was practicing at UK and just noticing how many people she was treating as a hospitalist for endocarditis that had untreated addiction. And it was really her noticing this and starting to write about it, which is usually a healthy outlet for academics when they're concerned about things that they're seeing in their patient populations. And that was just commenting on how, this person comes into the hospital. He's already had 2 valve replacements. This time he gets a mechanical valve, needs several weeks of IV antibiotics. He needed to go to a skilled nursing facility, but they were denying care because of the person having an addiction. And, the person was struggling with opiate withdrawal and cravings and was asking for medication help. But at that time, back in the early, 2010s, all the staff just thought he was drug seeking, and he was never offered medication treatment for opiate use disorder. And so he started leaving his room. Nursing would call security, chase after him. They would do room searches looking for illicit drugs. He was made to sign a behavioral contract. And soon after discharge, he returned to IV opiate use and later died after an extended stay for yet another valve surgery. So I'm happy to say that we don't have any more cases of Mr. M at UK, because we now have a addiction consult service that Dr. Finucchi leads, in large part through the support of our state and core funding. But this has been a problem across all the United States. So we're not picking on Kentucky by any means, but this is very common, like where, the treatment of addiction has been outside of the medical system for a very, very long time. Addiction medicine is only been recognized as a medical specialty by the American Board of Medical Specialties and the AMA in the last 10 years. So it is a relatively new specialty. And so we're really catching up. And so I just think it's important for the communities to know, because they might have to ask for the medication. It might not, it's not like an autopilot thing everywhere in every community setting. Like if someone had a stroke, and you had high blood pressure, the team would say, well, we better treat this high blood pressure, right? So that's what we need to do with these serious infections. Oh, does the person have an opiate use disorder? Oh, yes. Let's see if they would like to be on medication treatment, because that's really the underlying disorder that's driving the infections. So hospital care for opiate use disorder rarely in the past has included medications for opiate use disorder, and it was frequently ignored. But we are seeing improvement with this, and we're starting to see more harm reduction, initiation, and linkage to MOUD. And this is being associated with improved follow-up and fewer readmissions. Discharge transition is still really challenging. It's hard to find sometimes residential settings because the patients are very medically ill, and a lot of outpatient residential, even residential treatment settings are not used to taking care of really medically ill patients. So this is we're trying to really get our acute care internists, other types of clinicians trained up on addiction so that they can help with this. We do have ongoing studies demonstrating that, people can do quite well if offered treatment, and can even administer antibiotics through a PICC line as outpatients. And it's really a myth that everyone is going to inject into their PICC. You do have to do careful screening, but it is quite possible, and people can have great outcomes. This is another case that is quite frequent, where we see in the emergency room. So Mr. X is brought to the emergency department by EMS after an opioid overdose. He's revived with naloxone, and the mother is in the ED with him. But they're not offered overdose education, a naloxone unit, or a prescription for naloxone. They're not screened for opiate use disorder or offered to start buprenorphine treatment. They're discharged. The ED discharges him while he's in withdrawal because he just got naloxone, right? So that reverses the overdose, but it also precipitates withdrawal. And they just tell him not to use anymore. They recommend Narcotics Anonymous meetings. He returns to opiate use, and within 24 hours is brought to the emergency room department with another opiate overdose, but this time he dies. So really the recommendations now are really that emergency departments treat the opiate use disorder, that they screen and they offer, and if accepted, they start buprenorphine in the emergency room. There's no reason not to do it. There's NIH funded, not industry sponsored studies that demonstrate it can be safely done, quickly done. It's not time consuming, and that it helps people link to care as well. So, you could say, well, why isn't this already happening? And so lots of the things that we hear and that are published basically say that, doctors or physician extenders simply don't believe in it. And that is just something that we shouldn't be tolerating in our communities. When the ED was asked about why naloxone was still sitting unused and not given out, well, many of the answers included nurses or other staff or doctors believing that it enables opiate use. And so I was very grateful to hear these kind of statements, because it allows us then to have a conversation. And really the data show very clearly that it doesn't enable. What it does is it helps people understand an illness that they have and how they can better stay alive. So it's not making their addiction worse. And there have been several studies that demonstrate that. Here's a SAMHSA guideline about the use of medication treatment in emergency departments. And it has even has a whole section about addressing the myths, about implementing evidence-based programs. This is the emergency department trial that was really a seminal study that showed a twofold increase in attending the first outpatient appointment if they were started on sublingual buprenorphine in the emergency room. 78% followed up with outpatient addiction treatment versus if they were just kind of given a referral but not given the medicine in the ER, only 37% showed up. And then here what they showed, they did a 6-month follow-up, and they found that 50 unique emergency departments were giving buprenorphine. Rural and urban emergency departments were showing a decreased odds of overdose, which was awesome. 50% of people were engaged at 30 days in treatment. And so this is exactly the kind of thing that, you know, it's not a huge amount of time. It's not a very expensive thing. It's actually very cost effective that can have a huge impact on the community and on individuals' life. So what does appropriate care look like? So we really wanted to mimic care for other chronic medical illnesses that can have poor outcomes, like cancer, diabetes, bipolar disorder. We want the care to be available along the entire care continuum. It's not going to be helpful if, you know, people can't continue on the medication that's prescribed if hospitals and EDs say that they won't provide the medication for addiction treatment. Imagine if that was the case for diabetes and insulin, that when you get hospitalized that they say, oh, sorry, we can't give you insulin. We want it to be individualized to each person's needs. Okay, so it's not a cookie cutter, like where, you know, everyone, you know, needs to be on this dose and everybody needs to have all the exact same services. We want to have tailored treatment plans. This is what happens with, you know, with people who have diabetes as well, and with bipolar disorder. We want there to be recovery support services to be available along with the medication treatments. We don't want to see them as at odds. And we don't want to withhold medications because the person doesn't want to have therapy. What does chronic medical disease care look like? So really thinking about trying to parallel with diabetes and cancer, if you were to remove the stigma of the addiction, where there's an essential role of medications. They help people stay alive. Psychosocial and behavioral treatments and modifications and use of recovery support services should be tailored to the individual. We want to monitor outcomes and adjust treatment to the individual. Just like, you know, you might have to change the type of insulin or the type of oral diabetes medicine that the person might need. It might be that at one point they need insulin, at another point they don't. Just like I've had patients who've been on, you know, who've been on methadone, and other times in their life they've been on buprenorphine. And I've had patients who've also been on all three medications. There's been times when they've been done just fine in an outpatient setting, and there's been other times where they needed to go inpatient or to a residential treatment program. Just the, you know, there was adjustments based upon their illness. Treatment goals, you know, our treatment, we're typically not curing, we're putting into remission, we're improving organ function, and we're trying to prevent morbidity. So, you know, we know what happens with untreated addiction, that people have increased risk of getting serious infections. We want to prevent that, just like someone who has untreated diabetes. If we don't treat it adequately, they have an increased risk of going on dialysis. So we're trying to prevent that. And we're trying to really help improve the patient's function and role that they have in society so they can have a life, right? So they can have a beautiful recovery. And really the most logical thing is to have a stepped care approach. So not everyone needs the full court press. Some people are going to need the full court press, but many people get quite well and can go into remission and have a beautiful recovery with not much more than medicine. But you want to monitor people and you want to give what they need. Addiction treatment really must enter mainstream medical practice, or we'll continue to lose good people. I've heard, you know, like that, you know, a lot of primary care, it's just too much to take it on. They worry about diversion of the medication. And I think it's really exciting that we now have weekly and monthly depot buprenorphine. And so this obviates the need for sublingual medication and really greatly decreases those concerns. And they are also on the formulary for Medicaid. Overall, you know, we're trying at the base of things are always that therapeutic clinician-patient relationship, appropriate and therapeutic prescribing practices, the use of psychosocial and behavioral treatments, including referrals to care for comorbidities, the use of case management. You know, we want to make sure that all of our patients have their basic needs met. If we all remember Maslow's hierarchy of needs, where at the very bottom, you know, is basically like food, housing, just basically general safety. It's very hard if you're struggling with like foods insecurity and housing insecurity, to get to appointments and to adhere to your treatment regimen. So that's, I think, where a lot of our case management services kind of come in. And then we want to have objective monitoring of outcomes. We usually do most of our objective monitoring. Big part of it is through urine drug testing. Hopefully at some point we'll have saliva instead of urine. Having good collaborations with our pharmacists, and there's always ongoing education that we're doing, and we all have mentors as well. Overall, the principles of treatment are that it's a medical disorder. Genetics and environment are both at play. Because it is infected by the environment, there's always public health interventions that we can intervene with as well, and try to prevent the onset of the disorder in the first place. But when the disorder is present, then we want to treat it, and it is often chronic and relapsing. Medication treatment's a standard of care according to both SAMHSA and the American Society of Addiction Medicine. Treatment's more than a script for a medication. It's individualized to each person and their needs. Treatment's about more than just relieving or treating withdrawal. I wish it was just getting people through physical dependence and withdrawal. But please remember Lexington Narcotics Farm in the 1950s and the Public Health Service, where we demonstrated then, and we've demonstrated since then, that the return to use is what is the frequent outcome. So this is more than just physical dependence. Many areas of the brain have changed. Medication is often the foundation to give a patient a fighting chance to stay alive and make different choices. And hopefully we can get different condition learning and reinforcement in our communities to support that treatment and recovery. And that treatment does save lives. I showed you many, many slides that I hope that you'll take with you and remember. There is some more recommended reading if you're interested. The Legal Action Center is really trying to push emergency rooms, suggesting that hospitals are violating federal law by denying required care for substance use disorders in emergency departments. There's a clinical guideline here for treating pregnant and parenting women with opiate use disorder and their infants that just kind of goes over and has lots of basic pamphlets and kind of like tear outs, or you could download also for free, just about effects with breastfeeding on fetus and neonate, as well as mom. There's some other studies or scientific statements from the American Heart Association about managing infective endocarditis with people who inject drugs, really recommending harm reduction services and wide access to MOUD, and then a consensus statement from the Society of Hospital Medicine as well. So we're just seeing lots of organizations really come on board, supporting what the science has shown for a long time, that this is a legitimate medical illness and very worthy of treatment. We've a toolkit for jails and prisons about MOUD there. We have the Surgeon General report, which is really lovely. And then we have two assistant U.S. attorneys, Sinkman and Dorchak, that are talking about trying how to use the Americans with Disabilities Act to help reduce overdose deaths as well. And with that, I will stop and open it up for questions.
Great. Thank you, Dr. Lawfall, for that presentation. We have several questions and we'll try to get to as many as we can here. So the first one is, how do we make changes toward equal access and encouraging those that are non-white to seek treatment?
So I think it's really important that our clinicians and anyone who's doing outreach work, peer support specialists, that we make a real effort to hire people that look like different ethnicities, right? That not everyone is white, because that's really important. People want to be interact with people that look like them. So I think that's one very concrete thing that we can do.
Great. Next question, I think we just need a little clarification. The question is, isn't Suboxone a combination of naltrexone and buprenorphine?
So you're very close. It's buprenorphine and naloxone. So naltrexone is the long-acting opioid antagonist. That's Vivitrol. That's the shot in the buttock once a month. Naloxone, the brand name is Narcan. That's the overdose reversal agent. Naloxone is what is in Suboxone. So it's not absorbed well underneath the tongue when taken properly. But if someone was to try to dissolve and inject the Suboxone, then the naloxone is fully bioavailable and would prevent the positive opioid agonist effects from being felt for like the first hour and a half. And then that makes it not all that rewarding.
Great, thank you. The next one is more of a statement from Melissa, but I wanted to share it here. I was recently in UK's emergency room and noticed that they have signs that medications for opioid use disorder is offered in the ER. This was so refreshing to see that folks don't have to wait for their appointment to be scheduled and they have access to services right then and there. I just wanted to, if you wanted to speak really quickly about the work that went into that or how it feels to get that feedback.
Oh, it just makes me smile. Oh, I love that. Thank you for sharing that. That's, yeah. Thank you.
Yes. Next question. How do medications for opioid use disorder prevent overdose?
So that's a great question. So this is, I mean, we're just really lucky in this sense that we have opiate receptors. And so the medications bind to the receptor. And I'll just talk about, I'm just going to talk about buprenorphine as the example here because it's the most commonly employed of the FDA approved medication. So buprenorphine will bind to the receptor. It binds tightly, so it has a high binding affinity, and it has what's called a slow dissociation constant, which means that it's going to come off very slowly. And buprenorphine has a long half-life. The sublingual half-life, meaning how long basically it takes to get out of the body, is about 36 hours, and it's about 5 half-lives to get 95% of the drug out of the body. And the half-life is about 24 days with the buprenorphine and monthly injection. There's 2 monthly injectables now, and one has even a longer half-life. Sublocade has a longer half-life than 24 days than Brixadi, which is the newest monthly. And so what that means is that if the person takes their medication, that the buprenorphine is sitting on the mu opiate receptors in your medulla oblongata. I like saying that word. That's the part of the brainstem where that controls your breathing. And so the medicine is there. So when someone has a return to heroin use or fentanyl use, because buprenorphine has such a high binding affinity, it's very sticky. It wants to be there. And it has it's higher than heroin. And so it's not going to let the heroin bind. So it's like the person is protected because the medicine is there. Does that make sense? And it's because the buprenorphine is also in like part of the center part of the brain that is produces reward, that the heroin can't bind there either. So the good effects, the energy that someone would get, the liking of it, the euphoria, that's also blocked because the buprenorphine is there. So that's the mechanism. And so it's the same mechanism with naltrexone. If someone is taking naltrexone is binding to those same receptors. And it also has a nice binding affinity for it. And it also has a long half-life. And because it's also a monthly injection. And so as long as the person is getting their monthly injection, then if the person has a return to use while naltrexone is on those receptors, then the heroin's going to really struggle to bind there too and cause, the respiratory depression for the person to stop breathing. And then they're not going to feel like the energy and the liking in that as well. It becomes like a waste of money. It's all dose related too. So, if someone is using something like using a lot of heroin or a lot of fentanyl, it might be that they feel some effects, but that's why you go and you see your clinician so that they can be talking to you about if you're still struggling with stopping your use, that, and you're still feeling the effects when you have a return to use, that can be an indication that you need to have a higher dose of your medication. So it is important that you're receiving treatment with the clinician, and that you're following up, and that you are not feeling ashamed about talking about, returns to use, and that there is this like non-judgmental attitude that we need to promote honesty.
Follow-up question to this subject. Could a person try to override the Suboxone and use and potentially overdose if they tried to override the medication?
So yes, they could. I think what we see most frequently is it's not that, it's really that someone will just stop taking their medicine. And then you are not going to be protected. And so, it's an important thing that you should be talking about with your clinician too, is, the fact that if you're starting to think about or misusing, these are conversations that should be taking place.
Next question. I see several people in the chat mentioning kratom as an alternative for opioids. Specifically, someone was curious about whether it is possible to discontinue methadone by replacing it with kratom. Your thoughts on this?
So kratom is available in a lot of like head shops. Kratom is like a combination of both an opioid and a stimulant. And so it's, I don't recommend it. I've had patients who've tried it on their own and none of them have done well with it. They frequently end up becoming addicted to kratom, and it's hard. So I don't recommend it, but theoretically, yes, you could.
Next question. Do you see a point in time when opioid misuse will decline based on the multiple strategies, prevention, early intervention, treatment, and restricting available of the supply? Do you think we're seeing an improvement, I guess?
I think so. I mean, I think that, I think so. I just think that it's so prevalent. It's really hard, at this point in time, because it is at epidemic levels. So it's just, I think I do. I think through the healing community study, it's been an incredible opportunity and partnership with so many unique agencies and people and communities. And there's so many people that want to help. And I think that's what's needed, because we're all connected. So, and I think that this is a disorder that spreads among families, within social networks. And I think it's like what I've seen is that there hasn't been a good understanding among everyone that needs to understand about the nature of the illness and the nature of the treatment. And so, and I think when we explain it and we have open, honest conversations, that there is an improvement in understanding, and that there can be then a change where there's less stigma, there's more encouragement of treatment. And I think that's what's really needed. And I know I've seen so much improvement in the workforce and willingness to have more of a workforce and education and improvement in training programs. And we've had a huge growth, I think, in smart community recovery meetings, willingness of communities to, offer space for them. And so I think that there is improvement.
Thank you. Next question. Wouldn't the administration of buprenorphine in the emergency department increase the precipitated withdrawal?
No. So, great question. And that was it's a very legitimate question. There's a recently published study by Gail D'Onofrio. I think it's over 33 emergency departments across the country, mix of urban, rural, mostly people lots of fentanyl, people being with opiate use disorder offered to initiate treatment, and doing withdrawal assessments, sometimes waiting in the emergency room if there's not enough withdrawal yet, and then given either sublingual Suboxone or weekly Brixadi, and less than 1% had precipitated withdrawal. And that study was just published, I think, in JAMA Open Network. So that was really great to hear.
We've heard you mention Brixadi a few times, and I have a question in the chat. And just what are your general thoughts about the new medication, Brixadi?
So I just think it's a great other option to have if we think about, how many different medication options we have for major depression, for hypertension, asthma, diabetes. We want to have as many options for patients. It's not one size fits all. And so I think it's just more opportunities. So I think it's good.
Next question, Dr. Lawful, do you mind to share if and how your personal views have changed on addiction and medications for opioid use disorder since you began practicing?
Yeah, I'm old. I think like in the beginning, I'd get more upset with patients, or I'd get really scared or fearful sometimes, like that bad things were going to happen to them. And then that would, I think, just as a clinician, make it harder for me to have like the super honest conversations. And that over time, like the patients have taught me, and I've, learned from others that have been working in the field for longer than me, and work, family members affected. And so I think I think all of that has affected me. I think it's impossible for it not to. And I have like a lot of hope, and I see, I continued to work in the field. I don't have a high frustration tolerance. So for me to have stayed in the field, if you know me, means that I've been positively reinforced. So I've seen a lot of patients get better, and oh my gosh, like that were so sick, like so sick. And I think that's just the most rewarding thing. And so it's like, I know, like I've said, like the science shows, but I also know, like, as a human being, we frequently need to see things to believe things. And I've seen it repeatedly over and over and over again. So the science and my personal experience are both, really well aligned. And it's just been, I think I'm very grateful. I'm very grateful for all the patients who, have volunteered, to do the science, and grateful for the patients and their families willing to kind of come into treatment. It's, it's much easier now than it was in the past. It's stigmatizing now. It was much more stigmatizing, 10, 15 years ago. So.
Great. Thank you, Dr. Lawful. That will actually be our last question. We're going to move it over to Diana, and we'll go through the CEU process. So again, thank you for the wonderful presentation. And Diana, I'll get you set up here, and we'll go through the CEUs.
Okay, thanks.
Just a second.
Wonderful presentation. To receive your CEUs for this session, you will need to have attended 90% of today's training. And please note that these will not be available until after November 1st. You will receive an email with the information you see on the screen. You log in to MTS. You use the email address and name that you used today to register. And just a little hint, when you receive your email, use that address, and that should match what you registered with. Any questions you can submit to Kentucky School Virtual at ky.gov, and we will respond to anything that any question you have and help you. Thank you.
Great. Thank you, Diana. And just to share a little bit about some upcoming presentations we have, the next Kentucky School Virtual Session will be on November the 8th from 2 to 3. We'll have Dr. Anna Marie South from the University of Kentucky Her presentation will be Health Inequities and Social Determinants of Health in the Treatment of Patients with Substance Use Disorder. And then following that will be on December the 6th at 11 a.m. We'll have Dr. Elena Tackett from the University of Ohio will present on use of emergent products, vapes, flavors, and oral nicotine. All of these sessions are free, still have CEUs attached to them as well. And we are also really interested to hear if you have subject topics that you would like to hear about. Please email that to Kentucky School virtual@ky.gov. The goal is to have Kentucky School go through March of the new year. So we'll have 2 sessions in January, February, March, and that will wrap up our Kentucky School session. Again, thank you all for your participation today. If you have any questions, just reach out to us by email. Thank you.